I was going to say that's kind of like a philosophical question almost.
Yes.
So, I mean, I think we've sort of talked about minimal residual disease, but I think still the best image of minimal residual disease that people like to put out there is the iceberg, right? So, so what we think of when we talk to you about being in complete remission is you're not seeing the iceberg above the water anymore. So when you look in the microscope, you're not seeing it, and we say, hey, you're in a complete remission. But lo and behold, there's all this other stuff that's still there. We just can't see it. And so that's what minimal residual disease means. And so there are different modalities that can help us look deeper to try and see if we can actually not detect what's under the water anymore. And so that is where these tests come in. You can do that with flow cytometry. And in Europe, that's actually the preferred test. They found a way to use a lot of different colors, a lot of different proteins to really get, count over 1 million cells, for example, or 10 million cells to really look to see if they can find any myeloma cell in those. And if they can't, they say it's minimal residual disease to 10 to the minus 5, 10 to the minus 6. The other way to do it is this test NGS that Caitlin was talking about earlier, where you're actually using these very sensitive measures to, again, see if you actually can find that signature that you had. The problem is, to do that, you have to have sent a specimen from your original biopsy to the test that does the minimal residual disease to find that signature that is specific to your myeloma. And then, after you get treatment, if you go into a complete remission, you get another bone marrow biopsy, a sample gets sent, they do the NGS testing to see if they can find a signature again, and if they can't, then they say you're in minimal residual negative state. So, so that is now a better measure or a deeper measure to tell you that you're in a deeper remission. What we know is that if you can get to MRD negativity, it seems to be translating to staying in remission longer. And what we also know is that it seems to be a good thing to do regardless of whether you're high risk or standard risk. So that is a good goal to get to. What we don't know is what to do with that information once you have it, whether you can stop treatment, whether you need to add more therapy for those who may be MRD positive. And that's where we're talking about in terms of not knowing what to do with that information. So I would argue that it's it's a good thing to get to, so you may want it just to know that you're there, but it doesn't help us determine what to do next with that. And that's where the current studies are looking at in terms of whether we can act on that information.
So I think maybe to poll you all, are you checking it regularly on your patients?
Yes.
So we should probably talk about the why in the concept of what you just said. So I think minimal residual disease is clearly the somewhat present and definite future. We are looking for endpoints for multiple myeloma that are attainable and prognostic now. Because what a great problem we have that we are having a hard time anticipating and estimating overall survival because patients are living so long. And so instead, if we can say that we know that there are specific data points that are likely going to correlate with how long you'll live, it gives us some information that is tangible right now. And so minimal residual disease is commonly checked after your transplant or when your doctor, if with or without transplant, thinks that you are in a remission. And that means that your M spike has disappeared, your immunofixation, if not on daratumumab, shows nothing there. Your doctor says, it looks like she's in a complete remission. Let's do a bone marrow biopsy to test. So the bone marrow biopsy lets us look for the top of the iceberg, and then the next generation sequencing or flow gets sent off to a certain lab, which can look for under the surface at the iceberg hidden underneath the water. We are able then to come back with a report that says, we counted 1 million cells and found 9 cells, for example, that still have myeloma barcode or blueprint there. Or it may come back and say you have 0, and what we would call minimal residual disease undetected, I heard is the word we're supposed to start using, undetective instead of negative. And so when we're thinking about what does that mean, the short answer is like we said, is, well, I don't know what to do with this, because patients love to say, well, I'm MRD negative. Can I stop my Revlimid maintenance? And short answer is don't know, but wonder if you do serial checks. So say I find that you're negative at one point, and 1 year later we check again and you're still negative, I'm gonna feel a little more comfortable starting the negotiations about your Revlimid maintenance or whatever it may be. The proof will truly be in the studies that are ongoing, which are starting, and we're starting to get some initial readouts on, that are taking patients from their new diagnosis, starting their treatment, heading, let's say, with a plan of treatment, transplant, consolidation, maintenance, and checking MRD tests along the way. Because if the holy grail is going to be MRD, the big question is, well, when can we stop therapy? Maybe we can stop therapy sooner than maintenance, or in the midst of maintenance. Maybe we can stop it. Maybe you don't even need a transplant. We don't know. If we think that the goal is MRD negativity, maybe the answer is when did you get there? And that's the time to stop. And so there's a trial ongoing, the MASTER trial, which is asking this question. If we have a plan set out for you to start treatment, transplant, consolidation, maintenance, et cetera, let's check 2 different time points. And as soon as you are MRD negative 2 times in a row, let's stop therapy. Absent of those clinical trials, we're kind of making it up as we go along. And so yes, I confess, I check it as well, mostly because I want to know. Not because I'm going to say, let's stop this or let's start this. But I think eventually I'm going to be able to make that decision. As it stands right now, I think a lot of us kind of academic docs are doing it. I don't know if it's prime time for community oncologists who may not even know how to check it. There is a major company, Adaptive Biotech, in the country that does the next-gen sequencing. There are a handful of hospitals and universities that run next-generation flow that are out there and available. But I would caution to say we don't know what to do with it yet.
Before you give it to Ajay, I thought of another reason to do it. So there are now clinical trials that you would only be eligible based on whether you are MRD positive or negative at a certain time point. So if you don't know, you would not be eligible. So that's another reason to potentially think about doing it.
So I think there's a lot of issues with this test, starting with some technical kind of boring stuff, but really important, which is about 10% of patients, whether by flow or next-gen sequencing, are not evaluable. So imagine you've gone through the trouble of getting a marrow, and you're one of those 10% where we don't get that. So we're putting all of our eggs in this one basket, and it may not work, right? Next is, there's a lot of issues with sampling. So remember, when we're doing a biopsy, we're just taking out that liquid. Depending on how much liquid they pull out, by the time you pull out enough liquid, it's just blood. It's not aspirate anymore. The difference between a bone marrow and blood is very easy to tell. If you ever looked at what they're doing, there'll be nice, juicy fat particles. Those are called spicules. That's a good quality specimen. If it's just looking like blood, it's blood, right? And so you're putting all your eggs again into this one test, which could be completely inaccurate based on whether they sent it to the lab on that first amount of fatty specimen or that last amount of pure blood. Next question, raise your hand. Given a choice between marrow or blood test, what would you rather do? Anybody vote for marrow? No. And there's a real danger to doing the marrow because myeloma can be very heterogeneously involved in the marrow, right? So you can have one patch of disease and a centimeter over completely negative. And that's called heterogeneity, obviously, or patchy marrow involvement. This doesn't even take into account radiologic imaging, right? So if you're doing a marrow and it's negative, and you have PET scan or MRI showing residual disease, this bone marrow is useless to you, right? So we really need to do blood testing, urine testing, and as was mentioned this morning, mass spec, I think, is really going to be changing. If you've ever watched CSI or those TV shows where they can detect like microscopic amounts of either a poison or toxin, guess what? We can do that now for myeloma, right? Because you heard that these snipers are shooting off antibodies. That's what we're detecting. These antibodies can be detected by these new technologies at almost 1 in 10 to the minus 7th. So what would you rather have? A painful marrow, potentially getting blood, missing the spot of disease, and getting a non-diagnostic specimen, or an easy-to-do blood assay, right? So I think the future will be very different if we have that test. And then we also, so that's all testing related issues, which are kind of like, usually pathologists talk about that. We even clinicians don't talk about that. But we as clinicians need to know these things, because if we're going to act on a test, we have to know these false positive, false negative results. Was it a valid test? Then there's the actual, what do you do with an MRD positive? As we discussed before, there are many studies to show if you're MRD positive and that's an MGUS clone, that's not going to kill you. That's just going to hang out, and you're going to add drugs and potentially cause side effects chasing this non-issue disease. Conversely, if you're a high-risk patient and you have one MRD negative time point and you discontinue therapy, that's also meaningless. You need to sustain that MRD negativity, right? So there are issues with both positive and negative, and we've discussed briefly also the immune microenvironment, right? So the same two patients with MRD, the immune system can matter. And then the last part I would say is, in medicine, we distinguish between what are prognostic tests and predictive tests, right? So prognostic test is like the international staging system we talked about earlier this morning. Okay, you know the crystal ball tells you what kind of myeloma, but it doesn't tell you what to treat with, right? In contrast, the 11-14 translocation that we've talked about, that's a predictive test. If you have that, it really helps us guide therapy. We should use venetoclax. So which one is MRD? Right now, it's a prognostic test. And that's the challenge you hear, because, okay, you get this result, but what do you do with it? And so until we have studies where they're prospective, not retrospective, because the problem with retrospective is, did the patient get to the MRD testing, and how did they get there? Was it negative? Did it matter how you got there? Was it with transplant or without transplant? There's a lot of issues to that. If you do it prospectively, everybody's getting treated the same way, everybody's getting marrow done at the same point, and then you're making decisions based on that if you're negative or positive, then it has the power to be potentially a predictive test, right? But right now in 2020, I think the only use is clinical trials, and even clinical trials, the FDA is only going to allow MRD to be used in clinical trials where there's a problem with using regular endpoints, right? Everybody would like to see people living longer, but that takes a long time. Everybody would like to then see next the remission lasts longer, but that can also take a long time. And that's the only setting where MRD can be used. So newly diagnosed studies, maintenance studies. In heavily treated patients, you don't need this test. The disease is going to declare itself. If you're lucky enough to get a long remission, that's much more important than MRD. So I think even in clinical trials, it really only belongs in very restrictive spaces. So outside of that, I would say the two times we can use it in the real world at the bedside is in patients having toxicity with therapy, low-risk patients to consider discussing discontinuation, and potentially the other extreme, high-risk patients we're very worried about if they're positive, having, again, off-label discussions about whether we need to do more to try to get that patient to remission. But other than those two settings, I don't think we have any data in real world.
So I heard this analogy from Jesus about the iceberg, right? And I remember that I used to use this analogy quite a lot until a patient in Wisconsin said to me, "Are you saying I'm the Titanic?" So I kid you not, I was like, oops, no, I'm not gonna use that analogy before. So, I was trying to save the conversation from then on. So, seriously, it is a good analogy. And basically the way that I was describing it, again, in the ice and iceberg, which I guess in Wisconsin also made sense, was that, with initial treatment, you shave off the tip of the iceberg, and then you want to end up to an ice cube, right? And, just shave off as much as you can. But beyond analogies, it sounds like I'm coming from heaven. Beyond, there are two issues that I would like to, in addition to what my esteemed colleagues pointed, which is really the state of the art. Don't forget that even if you have MRD negative at what we call the 10 to the minus 6, which is one cell, we cannot find one cell in a million. That doesn't mean that you have 1 million cells in total. You have much more than 1 million cells. So that's just a fraction, 1 in a million. but because you have a lot more than 1 million cells in the bone marrow, this simply means that there may be X amount of cells left behind that we cannot detect. That's number one issue. So the second is that the question that often arises is whether if you are MRD negative or you become MRD negative, but you are also P53, you have a P53 mutated myeloma, whether that rescues you from the bad prognosis of P53 mutation. And that is a very risky territory. We don't have enough evidence to know whether that's the case, but there is no, at this point in time, a patient who is MRD negative but has high-risk cytogenetics, it is not clear whether MRD negativity reverses some of the adverse prognosis of the high-risk phenotype. So I would be very, very careful in this scenario. So how the two interlink is.
I think we're great. No, these are not even FDA approved yet. So they're still under investigation. But the one other point I think we've been agreeing too much, so I think we should disagree a little bit. No, but have I? No. But actually, I completely agreed. Up until this last year, there was no publication, but there was a recent blood publication showing that in patients who were able to attain, high-risk patients who attained MRD negativity did as well as standard risk. So for the first time, but that was in a transplant-based regimen. So again, most of the studies in the past, MRD negative and high-risk patients with high-risk disease still did worse than standard risk, but there may be a harbinger in the future that that's changing.
I would only add that obviously we're talking about MRD in the bone marrow, but obviously there's other ways to assess for MRD. There's MRD with imaging, right? So PET negative MRD is also an endpoint that you'll be hearing about, again, because of the potential that not all the disease is in the bone marrow, it may be elsewhere. So this even becomes more of an issue in the relapse refractory setting. So with the CAR T therapy I just showed you, we have a lot of patients, actually most of the patients that we test become MRD negative in the bone marrow, but then they relapse with a tumor outside of the bone marrow. And so if you're not using that imaging, then it's not, it's not as helpful. And so maybe a test like mass spectrometry that is actually looking at the protein, regardless of where the disease is found, may become easier to use and even more universal, perhaps. So we're all hopeful that that's the case.
So I guess I'll start with Selinexor. Caitlin. Okay. Selinexor was studied in a very heavily treated population. So the initial studies were patients who were basically triple-class refractory penta-exposed. What does that mean? They were exposed to bortezomib, Velcade, carfilzomib or Kyprolis, lenalidomide Rev, Pomalyst or pomalidomide, and Dara. So penta-exposed and refractory to each of those classes, which is really considered an unmet need. And so when this study was first done, and this was published in the New England Journal, this was a median of 7 lines of prior therapy over about 6.6 years. And again, that goes back to one of the earlier questions about functional risk. The gentleman who asked, if I've been in remission for 6 years, is that good? These patients had 7 different chemos in 6.6 years. So really, very high-risk disease, 50% of them had high-risk genetics. 22, from the day they signed consent form to the 12 days that they actually started the drug, there was a 22% increase in their myeloma numbers. So this is explosive disease, and many of these patients couldn't hang out for 4 to 5 weeks waiting for their cars to be manufactured, right? So this is the patient population. Many of these patients could have gone to hospice, and yet this drug with steroids alone worked in about 26% of patients. And so that historically has been the sweet spot for all these drugs that we've seen. For the FDA to approve what's called single agent approval, you need to have about a 20 to 25% response rate lasting about 3.5 months in patients who had no other options. So this is considered an unmet need. So Selinexor meets that criteria, and so for that reason, it got this accelerated approval. Now, the other big part about it is side effect management, which is there's 4 major side effects of Selinexor. One is GI, so nausea, weight loss. Second is blood counts, so in particular white counts and platelets. Third is fatigue, and the last one is low sodium. And so quite a bit of side effects, and it's gotten a lot of attention for that reason. And we had tough time at Mount Sinai in our initial experience with the drug as well. But by the time we had our first few patients, we realized this is not a drug that we've been seeing before in myeloma. I would say actually our solid tumor oncologists probably are more familiar with the GI side effects because a lot of the drugs that are used for colon cancers and other things are very aggressive and have a lot of GI side effects compared to myeloma. But we had to learn. And so in this STORM study, we became very aggressive with supportive care. So we gave triple drugs to prevent nausea. We checked blood counts. We told patients, I mean, these are patients where the way I've always explained to patients is, and the consenting part is very important. You tell the patient, this is a drug that's gonna work, but you have to use it at these doses if you're giving it as a single agent, and it's like you're trying to drive across a car ramp. If you don't go fast enough, you're not gonna make it across the ramp. So the point is we need to get this disease under control and then we can back off. Because the good thing is it has a very short half-life, which means when you stop the drug, side effects disappear very quickly. So when we tried all of these supportive care interventions, we have a manuscript that's now coming out. We looked at our responses compared to the overall population. And Mount Sinai, we accrued a quarter of the entire global study. So the entire study was 122, about 30 of them were from our site. And our patients had a response rate of over 53% instead of 26. Our progression-free survival was 5.3 months instead of 3.5 months. And our patients live on average 15.6 months instead of 8.6. And I give a huge prop to our nursing team. I don't think we appreciate and thank them enough, but they called patients, had them come in for hydration, gave these medications. And I think the key with all of these patients is that, okay, even whether it's 3 to 5 months, that's not a long time, but guess what? That's enough to go on to another treatment, right? This is like Tarzan. You've exhausted all your therapies, you're looking to grab one vine, and then when that's done, there's another vine ready to go. We have patients literally alive today in complete remission, either on CAR-Ts or bispecifics, that I'm certain would not have been alive today had it not been for Selinexor. So I think that is why we need these kinds of drugs. Each incremental addition is adding to our outcomes. And the last point I'll make is this week, there was a press release because what I told you was a single-arm study of Selinexor in 122 patients with DEX. This was a randomized phase 3 study where everybody got either Velcade and DEX or Velcade, DEX, and Selinexor. And Selinexor improved the progression-free survival, even though it was a risky study because the control arm got standard Velcade, DEX twice weekly, which is tough, has more neuropathy, et cetera. And in the Selinexor study arm, it was only once weekly Velcade, DEX. So even though much less Velcade, much less DEX, patients had a longer remission duration. So I think this will confirm all accelerated approvals need a confirmatory phase 3 study, and that was met. So I think it's an important drug in our arsenal, and actually our last point I'll make is that we had 7 patients with, in the initial STORM study, there were 2 patients with CAR-T that had progressed, and they responded, and we looked at a broader across multiple studies. So talk about very sick patients. CAR-T patients, as you heard, have also had 7 prior therapies. Now, after 7 prior therapies, you're giving them drugs called fludarabine and cyclophosphamide, completely knocking out their T cells for 1 year. Then you're getting through CAR-T, ending up with low blood counts, extramedullary disease. Talk about really sick patients. And we had 7 patients in this manuscript this week that just got published who responded on Selinexor-containing regimens and actually had remissions lasting longer in some cases than they did on the CAR-T, right? So I think this is really an unmet need, and it's a drug that we all need to learn how to give, and we're happy to share. In fact, I probably get asked at least once a week by some myeloma group or other, hey, what's your cyanide cocktail for treating patients? So, which we're happy to share. And now that it'll be published, we won't have to email.
So, no, I agree. I think it's a very different drug than what we had before. So it makes sense. It's a new mechanism of action. So these cells are not resistant to it. But I will caution that because of these toxicities, I think he just told you that at Sinai, people did better than anywhere else, and most of the anywhere else's were probably other academic centers, or at least it was controlled in a clinical trial. So now imagine going to the community, and a community doctor that may see 3 myeloma patients now starts the drug. I think it is going to take a lot of education and making sure, and you should be proactive, and it should be discussed with you, that these are toxicities that can happen or may happen that can be controlled if we're aggressive about being vocal about the side effects and treating them aggressively and then pulling back instead of waiting for the symptoms to develop and then starting the side effects. So I think it will be a lot of education because it is an important drug, but I'm worried that as it's used by people who don't have experience, that people might become afraid of it, and then it will stop. So hopefully that won't be the case.
I wanted to just add two quick things in response. I completely agree. One of the things we looked at in the manuscript is, okay, so that sounds nice, but how many patients came off for side effects? So in the entire global study, a third of patients came off for side effects, whereas at Mount Sinai it was 2 patients, so 7%. So I think the point is the vast majority of patients came off. In most clinical trials, they come off when the disease stops working, and that's what we saw here. The other important point is you've heard with all of the drugs that we've seen, this is not just Selinexor, in advanced myeloma, even a 25 to 30, even 50% response rate really is not enough, right? If you have a heavily treated patient, you need as best as you can, and we're not using any of these drugs either by themselves or with Dex. We're almost always using triplet regimens, right? And so when you do Selinexor, the future is not Selinexor and Dex alone, it's triplets, right? Whether it's Selinexor with Dara, with carfilzomib, with bortezomib, and that's how I think it'll be used, and that's important because when you add a third drug, you don't need as much Selinexor. You can use less Selinexor, which means less side effects, right? So I think that's really the point of the STORM study, the New England paper, was just to show that this drug works by itself, to get it accelerated approval, to distinguish it from drugs that have no single agent approval, right? So drugs like elotuzumab, panobinostat, ixazomib don't have any single agent approval. They are only approved in combinations, whereas carfilzomib, pomalidomide, Dara all do. And so the question was, which category is Selinexor? And Selinexor belongs in the category of drugs that works, but none of these drugs, and none of these 4 drugs, are going to be used as doublets. They really need 3 drugs to get maximal benefit.
Any more, or?
So speaking of no approval for single agent, Isatuximab just got approved 2 days ago, and I actually don't remember the Icaria. So it's now called Icaria. But basically, Isatuximab. No. Wait,
Study was Icaria.
Icaria is a study. That's right.
Sarclisa is the brand name, and Icaria.
Sarclisa. Correct. You're confusing me. So yes, Icaria was a study on which it was approved. So Isatuximab is an anti-CD38 monoclonal antibody. So it's very similar to Darzalex. Now there are some differences between the two in theory in terms of kind of how they work and the mechanisms of action for one or the other. But I mean, truthfully, when you look at them in all the different studies where they've been tested by themselves or in combination with other drugs, they seem to be acting pretty similarly. So the efficacy seems to be the same. The reason Isatuximab got approved is that this is the first randomized phase 3 trial in combination with Pomalyst. So the study was Pomalyst, dexamethasone, or Pomalyst, dexamethasone, and Isatuximab. And of course, the triplet, as we've seen with many other drugs, is much more potent than the doublet, and so that got it approved. So Darzalex is approved with Pomalyst Dex, but that was based on a single-arm study that actually Dr. Chari did as well. He seems to do all the studies. So I think it's an important drug. It does have less infusional toxicity, and it has a shorter infusion. So that is a benefit from this drug versus Darzalex. But then Darzalex should be FDA approved, hopefully soon, subcutaneously. And so that may obviate that benefit. So I think it'll be interesting to see how much more this drug adds to our current armamentarium. There is no data whatsoever in terms of whether you fail one, whether the other one will be active or not. Those studies are not available.